as well. All right, go ahead.
So at our last meeting, we started to really talk about service lines, and I had said to the group it might be helpful if I come back with a small presentation around service lines. And so here's my intent. My intent today is to share a little bit about service lines, sort of the what, the why, and hopefully how do they affect me, how do they affect you as individuals within the organization. So what I'll preface this by saying is this is a lot about the why. Why are we doing this? Why is our organization going through a lot of change right now at this point? So I'm going to run through this. I will say there's quite a few slides, but if you bear with me, I think it'll start to paint a picture of what's going on and why it's occurring. And then we certainly, and I hope to have some conversation at the end, but if there's questions along the way, at least for those of you in the room, please ask. And I guess, Nicole, if somebody asks online, you'll have to prompt me. But I'm happy to answer questions as we go along. So what's going on, within our organization, within our health system, and where do I fit in is really what I'm going to try to answer for you. Our agenda is up here. So why is there so much change? I think everybody's asking that and have been asking that maybe for the last year or two now. And it feels like we're living in an environment of change. What's the reason for all the structure and people changes? And then hopefully, if you're asking the question, how do I or how do we get involved, I'll open that up for discussion and maybe we can answer that. So I think everybody has certainly seen and knows the Christiana-Care way, but when you really talk about why are we going through all this change, it really starts right here on this screen and with this statement. We are embarking on really trying to bring the Christiana-Care way to life. And what I mean by that is we've all experienced, our culture and who we are as an organization. But when you really think about caring for your neighbors and doing that as partners in their health, and then you get into the other words of innovation and effective, affordable care, those things are what's driving our organization to really change. And I'm going to underscore the very last thing, which is doing all that in a way that our patients, our community, really find valuable. And so that word value really becomes a lot of the answer to why we're changing. But you may be thinking about this slide right here, which is, we're already doing great, right? So we're one of the top 100 hospitals. We've won the Everest Award 2 years in a row. We're on the U.S. World News report for best hospitals. We're a Most Wired winner for innovation in medical record and some of our electronic systems. We're a leader in LGBT community. We're magnets. So we're doing all these great things, and our health system has already received lots of local and national recognition. So again, why are we changing if we're already good or maybe even great? You could argue that fact. One of the things I want to call attention to is the Everest Award, and I don't know how many people are really familiar with Everest, so I just wanted to call it out. The Everest Award is at the very bottom there, is 17 hospitals are selected from 100 across the country, and there's way more hospitals and health systems than 100, but if you take the top 100 and then you bake it down to who's doing the very best, we're one of only 17 health systems in the entire country that have received this, and not only have we received it once, we've received it 2 years in a row, which is pretty phenomenal recognition. Why it is so interesting and so important is this really looks at how quickly organizations are changing and changing with improvements in quality and outcomes. And out of all the major teaching hospitals that have received this, and this is sort of a slide, if you look at the left-hand side, you'll see the rate of improvement between 2009 and 2013. And then at the bottom, you'll see performance overall. I'll call your attention to the box down the right-hand side, which starts to show mortality and complications and patient safety. You'll start to see quality measures. And so Everest really looks at how are we doing with quality and then rates us against everybody else. But more importantly, rates the rate of improvement that's up that left-hand side of this graph. So how fast are we driving improvement in all of these categories? And you'll see that number one, with the green arrow in the top right-hand corner, is at the leading edge. That's us. That's Christiana-Care. we're sort of leading the rest of the health system when it comes to how fast are we improving in all these areas, which is pretty phenomenal when you think about it. So we're doing great. We're receiving all these awards. Again, back to the question, why are we changing? Why are we going through all this? Well, this starts to answer part of that. So Delaware, as a state, spends $8 billion on healthcare. And when you break that down a little further, we're spending 25% more per capita than the average U.S. State. And so not only are we spending a lot of money on healthcare, but we're a quarter higher than everybody else. At this rate, 40% of income will be spent on healthcare by 2030. At least these are, from Delaware U.S. health costs. And this is reflective of 2009 data, but they were projecting out about 40% of your income is going to go to health insurance and healthcare. That's huge when you really step back and think about it. Premiums have gone up 5% per year over between 2006 2011, and 22% of our state's entire budget is being spent on healthcare costs. And so you look at this and you say, well, there's a lot of money being spent in Delaware. Well, guess who the #1 provider of healthcare in Delaware is? ChristianaCare. And so we have to take a look at these numbers and say, where is our responsibility in looking at healthcare costs for the state, for the community, for the people that we're serving? So if we're spending a lot of money, you would expect those quality indicators to be really good, right? Well, this is where the story changes a little bit further in that, diabetes presence over time is actually increasing. So we're spending a lot of money, but yet our prevalence is going up. When you start to look at things like blood pressure and cardiovascular risk factors, again, you can see Delaware compared to the U.S., compared to the best state in the U.S., and we're sort of out on that leading edge of not having the best outcomes when it comes to cardiovascular risk factors. When you look at disparities in Delaware's, again, you'll see sort of the same picture when you look at, white versus our African American population and some mortality rates between heart disease and cancer and a few others across the screen there. With all the money that we're spending, we still have some significant differences and opportunities to really improve our healthcare delivery. So I'll get back to this statement, which is the ChristianaCare way. And when you think about serving our community and doing so with value, you have to start to ask the question, if we're a state that's spending some of the highest dollars in healthcare, but yet our quality and outcome isn't necessarily comparable to what other states are doing at a lower cost, we probably have a responsibility to improve. And so ChristianaCare has taken a step back to say, as the largest healthcare provider, we have to start to respond to some of these numbers. So although we're receiving already some national recognition about doing some really good care, we have to do better. And that's really where the discussion starts. And so, again, I think everybody's familiar with the diamond, and I'm going to start at the top, which is really referred to as the triple aim, so optimal health, exceptional experience, and organizational vitality. And really where we're targeting is optimal health first and foremost, right? So all those things start to drive our change within the system. So why service lines? Traditionally, medical care has been somewhat fragmented, and it's really driven out of organizational structures around physicians or departments. And if you think about ChristianaCare over its lifespan, it was really set up departmentally to care for patients. But that really is organized around the physician. We're attempting to reorganize in service lines, which start to organize around the patient. So how do we care for patients? How do we change their experience and their outcomes? The organizational structure should be simplified in that, if you think about departments, there's quite a few of them, right? I don't even know how many departments there are within ChristianaCare. But when you talk about service lines, you'll see in a minute, we have 9 of them. It dramatically simplifies how do we start to focus on driving patients in a new direction. It hopefully enhances collaboration. So if you have 9 service lines, 9 service line structures should be able to talk to each other and interact with each other in a very simplified way, as opposed to talking about hundreds of departments needing to talk and work with each other. And then if you start to talk about care and care delivery, you hopefully have heard the term clinical pathways. There's lots of pathway work going on right now, which started over a year ago at this point. But we really want to drive how do we care for patients across the continuum of care. So not focusing in one site or one location, but how do we care for patients in the hospital? How do we support them as they transition back to their homes? How do we then follow up on that visit? How do we start to talk about prevention and chronic disease management in a way that it feels all integrated with the rest of our health system? The way to do that structurally is going to be through the service lines that are developed. This slide here starts to paint a picture of that. You've probably seen this around. I need to preface and say a lot of what I'm showing you are not my own material. You know, these are slides from around the organization that I've compiled. So not using this as my own material, but hopefully trying to paint a picture of what's going on. At the top here are the 9 service lines. I don't know exactly who all is on the phone, but I will say all of us in this room, and I assume everybody on the phone, really falls under primary care and community medicine service line. So our organizational structure sort of lives there, but the other service lines are who we're interacting with on a regular basis. And across the bottom of the slide is what is being now framed as essential services, which are all those pieces and departments and structures that support the service line functions, right? So service lines aren't the health system. And frankly, a lot of the work is really being carried out by our essential service partners. But we need to work in collaboration with the service line structures to make that work. Within each service line, there's a leadership structure. So service line leadership, you may hear it referred to as a SLED, which is a physician leader, in almost all cases also an associate physician leader, a Christiana Care Quality Partner or CCQP leader, a nursing leader, and an operations leader. And I'll talk in a little bit about our structure. We're not just changing service lines though. You know, you've probably seen there's been major changes in nursing leadership. There's changes in how we're focusing on health equity. There's changes in the essential services structure and those rolling up under Sharon Kerfurst. Our medical group and how we're interacting with our physicians that are employed is changing, and those connections are being grown and tightened. We're developing a learning institute through iLead. And then the service lines are really starting to take hold, but lots of other parts of our organization are changing at the same time as service lines are being developed. And that's really what I want you to hear. So again, why does all this matter? Well, when you start talking about how do we care for patients differently, across the center of the screen are some terms, but you know, self-directed medicine, evidence-based practice, reliable care, and shared decision-making are what we're trying to hardwire into everything that we do. And when you think about clinical pathways that are being developed, we're trying to promote efficient use of resources. So how do we do great quality care, standardize it, and reduce variation, and do so at a lower cost, getting back to those slides earlier about how do we do this in a way that doesn't put Delaware at the top of the map for the most expensive healthcare. You know, if we use our resources more efficiently and we standardize how we're approaching things, in theory, we should be able to drive down some of our costs. And that's what clinical pathways are targeting, not just driving outcomes, but also helping us do so in an efficient and standardized way. Not intending you to see all the detail here, but you know, these are just some quick process maps. And when you think about creating a process around care delivery, right? Either if you've been a patient or you know somebody who's been a patient or you've experienced healthcare in any way, you know that sometimes when you come and you get something done or you're seen and you come back, you may have a good experience, you may have a bad experience. And it changes almost time to time, visit to visit, right? That's variation. What we're trying to set out is how do we standardize the way that we provide care in all different areas of our health system. And by doing so, you start to be able to predict how the outcomes of those things will be measured. So quality can be gained, efficiency can be gained, patient experience could be felt like every time I come, it's not a new experience, it's the same experience, right? So if you think about other customer service industries, and the ones that do it exceptionally well, people go back there because they had great service, and every time they go, they have great service. Well, that's what we're trying to reproduce. How do we change the patient experience? So every time that they come through our health system doors in any venue, they get that same great experience every time. Well, that starts with understanding what is the process behind everything that we do. And we're starting to lay that out in a very scientific way. And service lines are the first place of that. So on the screen here, you'll see the 9 service lines. You'll see the pathways from last year. These are FY16 pathways. What I'll say is there's a whole nother 9 that have started in FY17. So starting in July, all the service lines have taken on a second pathway. What you'll start to see as you look down here, there's many different targets and focus around how do we change the way that we're providing care for these different patient populations. And again, doing so in a way that is process-oriented and starts to reduce variation. Other health systems have done this very successfully, and we're learning from their experiences. Intermountain Health is one that has been doing pathways for a very long time and is driving dramatic changes, again, both in patient outcomes as well as in experience. And what they find is they can get doing all that at a very low cost. Because once you develop the process that works, it's reproducible, right? You don't have to figure it out every time. So you'll see this, and I'll show you that out on the Christianity Way website, you can see and follow all the different pathways and the work that's being done in service line goals. So if you're interested in more of these, I'll show where you can really look and find that stuff. So we've talked a little bit about the why behind optimal health, but you've also heard me talk about exceptional experience, right? This is just as important as the quality and the outcomes. And I put this up here because sometimes, working around people every day, we see people, right? And we interact with people, but sometimes we start to take it for granted, right? We start to see a patient as a patient as a patient. Now, the color might be different, their shape or size might be different, their language or skin color might be a little different, but at some points we start to see patients as patients. Again, there's a different focus to try to bring some clarity to not just seeing a patient as a patient, but seeing a patient as an individual in a moment of care delivery. And how do you really start to do that? I hope that all of you have heard Dr. Nevin talk about empathy and gratitude and interactions with people, and the human touch, as it's being displayed here, is a whole nother level of patient experience. So I think all of us, as we enter into a healthcare setting, expect to be treated like the only patient in front of that provider or that service. But again, as healthcare professionals or working in the healthcare setting, we're seeing lots of people every day. So part of this change, part of the organization's process, is getting everybody to start to think about patient interactions and patient experience differently. And we're structuring ourselves around service lines, again, to really help with this. I'll go back to this same screenshot, right? There's lots of pieces in here. And I'll also refer you back to the Christianity Way. When you think about what our patients think are valuable, you have to start to ask the question, do they think each one of these steps on this screen are valuable? Would they be willing to pay for everything on this screen? And if the answer is no, then we have to challenge ourselves as an organization to say, where's the waste? Where's the stuff that we're doing because we say it's important? But how do we flip that back around and say what's important to the patient? And how do we start to really focus there? Again, when you start to look at the process of care, you can start to identify where are those opportunities and where should we be doing things a little different. And so core competencies around creating an exceptional experience is what are starting to happen across the organization. So Sean Smith and the patient experience team are really digging into how are other organizations really driving experience measures to an all-time high. And again, in the middle here, you'll see some buckets of things that we have to start paying attention to. So leadership, compelling values, customer expectations, micro interactions, and employee engagement. All these things are what patients really start to say are important to them, right? They want to make sure that as they're visiting, that they do have that micro interaction. So they want to feel a touch. They want to have access to things. They want flow to be easy. They want engaged employees interacting with them. They want happy people that are smiling and opening up conversation. They want their expectations to be met at the end of whatever that service is that they're seeking. And all that starts to come from that front end, which is how do we have leadership that's guiding us in the right direction? And how do we have values underneath all that? Underneath that Christianity Care way, where are the values that really dictate all these other things to happen? And so if you're a high reliable organization, again, going back to consistency and consistency and experience, we need these things to happen every day, every second of the day. And that's another driver of all the organizational change. And then last but not least is organizational vitality, right? So we need to be financially sound to be successful. And hopefully everybody's paying attention to the healthcare landscape, but lots of organizations and health systems struggling financially. Lots of hospitals closing around the country because financially they're not viable anymore with their systems and structures. Lots of things in the ambulatory space, private physician practices closing up, and all these things are forcing us to look as a health system to say, how do we sustain into the future? At the same time, I think everybody's also aware of governmental changes, right? So Obama and healthcare reform has changed the way that payment structures will be generated in the future. And so as Christianity Care, we're starting to certainly and always have looked at financial statements, but you'll see on this screen we have a positive operating gain in margin, just as we did last year. And if you think about TRP and other systems are really driving all of us to help Christianity Care be financially viable. Well, again, you may ask, well, we've been successful in the past. Well, why are we focused on this? This is just a representation. This is a couple years old on FY14 revenue, but this is the breakdown of Medicare, Medicaid, commercial insurance, and other. And you'll start to see that we have a lot of commercial insurance, almost half or a little more than half is commercially paid. But Medicare is a huge one out there, and Medicare is changing as we look at payers. So you'll see on this slide around our risk, Christianity Care is on the left-hand side, our payer at the bottom. And you'll see some of these terminologies, right? Capitation, CMS bundle payments, gain sharing, pay for performance, percentage of charges. And then in the green, you might start to hear names that you've heard before. So Highmark Medicare Risk Program, Model 2, the ACO or Accountable Care Organizations, VBP or value-based payments. So Christianity Care is living in an environment in healthcare where our payment structures are starting to change. We're moving from a fee-for-service where patients used to come through our door and everything that we did generated a bill, and then that patient was expected to pay the bill, whether it was through their insurance or through federally funded payment models. And that is changing now. What we are now being asked to do is keep patients healthy and well, more of the prevention side. And so getting paid more for patients that, frankly, don't come through our doors every other day. If you think about it, the healthcare system was flawed for a while in that you actually got more money the more time the patient came back to see you. So there was no incentive to keep the patient away from your hospital, to keep them away from your doctor's office. To keep them without getting procedures or testing that maybe they don't wholeheartedly need. And what is now changing is that payment model is focusing in on how do we do just that, right? So how do we get patients to be healthy and well, at least as well as possible, and baking in incentives for us as Christianity Care to do that. What that means, though, is everything that we've known in the past has been flipped upside down. And so from an organizational vitality perspective, for our financial stability, we have to change to catch up. And that's why you're seeing other health systems and other healthcare providers really struggling in the moment because they're trying to figure this out. They're trying to make sure they stay up with all the changes. And some of them, frankly, just cannot do so. And so they're closing the doors, they're shutting down. This is really important because although we've been really successful historically as a financial institution, we may not be as successful in the future. And that's why there's some worry, and you'll hear some concern about that. But with everything else that I just said, right, you have to have the balance between the business model and the clinical model. And that is another big driver of all of our organizational change. In theory, again, if you get back to why are we doing all this, we've talked a little bit about the optimal health piece and why we need to do so from quality and outcomes perspective. We talked a little bit about the patient experience. Well, financially, we also need to be sound, but we need to marry those other two with how do we operate within our own new business model, which is the payments that are changing from a fee-for-service to how do we operate in a new ACO and prevention and health environment. Does that make sense? So we come back to this, and I focused on the top because, again, you've probably heard about the triple aim. That is the triple aim of Christiana Care. That is our focus right now, and that is why we're changing as an organization. But we can't do that with what becomes the quadruple aim, right? That's everybody in this room and on the line. It's our extraordinary people. And we could have the best strategy, but there are some thinking, there is some thinking out there that culture, if you have the wrong culture, will eat your strategy. So it doesn't matter how good of a strategy or plan you have. If you don't have a culture to support it, you really won't be successful. So the same thing could happen to us, right? We could have this great sort of Christiana Care way, we could have this wonderful diamond, but if our culture doesn't support it, we really won't be successful. And Edward Deming would say that variation is life, or life is variation. No two people are alike, and that's absolutely true. So the other reason that you're seeing our organization change positions and structures and things at a rapid pace is we're trying to catch up with all the pieces of the triple aim, and at the same time start to really talk further across the horizon. What do we want our culture to be? Who are we as an organization that really becomes the foundation of service lines, of quality improvement, of exceptional experience, and really also helps us drive our financial stability? So I'm going to switch gears a little bit because that's all the why. That's why we're doing everything that we're doing, or all those pieces I just talked about. This starts to get into the how or the what. I don't know if anybody has seen this, but this is out again on the Christiana Care portal. You can get to the AOP dashboard. I encourage you to go there. All the service lines have now been asked to manage an AOP dashboard or annual operating plan. If you're not familiar with that terminology, senior leadership develop our goals as an organization every year called the annual operating plan. And historically, that has been pushed out to, again, leaders within the organization. But we have a new structure now, which is service line focused. And the service lines are now tasked to create our own goals as a service line that feed up to how are we going to help the organization achieve each one of those AOP goals that senior leaders and the board has set as priority for us. And a reflection of those goals are right here on this dashboard. So again, I'm just going to orient you to this. At the top, you'll see optimal health, right? That top part of our diamond. You'll see exceptional experience. How are we doing with what patients are telling us and their feedback in the middle? And then at the very bottom is that organizational vitality, or financially, how are we doing? This dashboard gets updated every month, and you can dig into here. You can click on all these colors and see behind it other measures that are really driving it. But what I want to say is all of the service lines are responsible for improving this scorecard each and every month throughout the year. And if we do so, that should help us achieve our annual operating plan. But more importantly, that gets back to why are we doing all this? It should start to challenge us to provide better care with better outcomes and do so at a lower cost with great experience for our patients. And so the service line structure is really allowing this to occur. I showed a slide at the beginning that had sort of the blue circles, if you will, with sort of titles and how each service line is structured. I just want to throw this slide up to say this is the leadership team that's led the leadership of primary care and community medicine. We meet weekly and are talking about all the AOP goals and all of the system changes, as well as what do we need to be focused on for primary care. We are also talking about the initiatives that we're collaborating with other service lines and other service line leaders. And we're also focused in on how do we create those new pathways that add value back to our patients and our system. And so this is the team. And the next steps really start to ask this question here. So where do we go from here, right? There's been lots of change to set up for all those reasons. We've all kind of felt that in many different ways. But the first bullet here, really starts to ask another question, which is how do we build on our success while we continue to adapt and transform the way that we deliver care? And I guess my message is we probably won't stop changing. What we should start to get used to is living in an environment of change, because for the foreseeable future, we need to start to improve and keep up with how do we continuously drive improvement and do so at a fairly rapid pace. It doesn't feel like our normal culture, right? It's not what we're used to. That's part of, again, if you think back to the little green monster that's eating our strategy and eating our diamond, we're thinking that we need a new culture to really help us fulfill that strategy. And so we're going to continue to have opportunities to improve and really feel that. And again, I'm going to highlight the bottom of the diamond, because the way that we do this really starts on the ground. It starts with all of us. And so you're going to hear right now, in the moment, things about values and behaviors. And we can make these statements down the left-hand side that we will be even better for our patients and families, for our community, for each other, because that's really what we want our culture to be. And then if you kind of take the arrow over to the AOP goal, there is an annual operating plan goal that you can find and read that really talks about engaging our extraordinary people, because everybody realizes that we need to have the right behaviors, the right values that really allow the service lines and that Christianic Care way to live. And so there's some real focus on that right now. One example are core value ambassadors, and you're going to hear more about this. It's really been kicked off by, again, our senior leadership. But there's going to be a team of, the last I heard, the number was over 400 people that have been nominated to be Christianic Care core value ambassadors. And they're going to help us understand what are those values and behaviors that we need to not lose sight of and hardwire into our culture. So it's individuals on the front line that are going to start to answer this question. This is where any one of you can start to get involved. If you're interested or have, again, an interest to be involved. Engaged conversations, again, is something you're going to hear more about if you haven't already. Dr. Nevin had kicked off this Engaged Conversations platform very recently, and you're going to hear from your managers and your leaders about engaged conversations. And really, it's just that. We want to talk about what are those things that you're seeing and you're identifying as opportunities to improve that is really the low-hanging fruit for us to change. What are those behaviors that you're seeing from others that, frankly, maybe we shouldn't be seeing, and we need to hold other individuals accountable? What are those values that you are seeing that are great, and we need to recognize and celebrate? All those things will be happening through engaged conversations as we start to change the values and the behaviors that really drive the foundation for the Christianic Care way. And I talked about AOP goals, or the annual operating plan goals. On the screen here is a draft, and again, this is out on the service line website. You can access this document. This has the primary care and community medicine FY17 goals. So if you're interested in seeing what are we doing as a service line that really responds to the annual operating plan, there's 29 initiatives that are focused directly within primary care and community medicine at the AOP goals. You'll see names in green that highlight who are the leads for that area. They're certainly not doing all the work, but they're the leads. And so if there's any of these areas that you're interested or you want to get more involved with, these are all opportunities and sort of front and foremost for us to get right in the next year. And then more importantly, we'll be adding to this list. So as we certainly don't think that it's an encompassing list. It's where we've started. As we move through the year, we'll be adding and subtracting from this list as focus changes. And as we move into next year, we'll be creating a whole new set of goals. And so this becomes the opportunity to really get things that you're doing in your areas or at your sites to be seen within the service line and really get resources and focused upon. But what we also want to say is we also need to start saying no, right? I'm sure everybody feels pressured with the amount of work and the amount of things coming your way on a daily basis. And the other reason for all this change is we need to start to set priorities for the organization. We need to start to set them for service lines. We need to start to set them for all of you so that we don't feel like we're being pulled in 1,000 different directions with no time to finish it. But yet the highest priorities are front and center. And if it's not on that list, we all start to question, should we be doing this? Is it something that's going to add value back to our neighbors, back to that Christiana Care way? And if the answer is no, it might be a really good thing to do, but we may start to say no to those things. Or we may say now's not the right time because we have 29 other priorities right now, and we need to get some of those off the list before we add another one. And so again, organizationally, creating a structure within the service lines for everybody to operate hopefully more efficiently and in a way that adds value and enhances your own experience as an employee. So I'm going to intentionally pause here, and I know we're almost out of time, but I hope that this answers a little bit about why are we going through all the changes that we are. What is going on with the structure and the people and the positions and everything kind of feeling different? What are we trying to target with all that change? Well, it really is quality, it really is experience, and it really is our financial stability. And the way that we're going to do all that is with everybody on the ground in all the positions. That's all of you, our extraordinary people. And this is where I would love to have some dialogue with the time that we have left, and certainly can even continue it outside of here or at another meeting, but we really need your help to identify what are those other things that we should be focusing on. And if you're interested in getting involved, I certainly can help you. We can guide you to the place to do so. So, questions, comments, thoughts?
Too long for 4 minutes. So.
Yeah, that's okay. And what I'll say is I'm happy to have a conversation. Yeah.
Is anybody chatting anything, Nicole?
One of the things I'd love to hear is, was this helpful, right? So I created this slide deck. You're sort of the first people to see it. You're my guinea pigs, but you're also the highest priority, if you will. So I would love some feedback to say, does this make sense? Was there parts that were confusing? But again, I was trying to paint a picture of why are we going through all the change. There's a whole nother slide deck that I'd love to create, which is what is our service line, what are all the pieces, and what's going on within just primary care and community medicine. But as you can see, putting it all together in one package becomes a little overwhelming.
Lindsay said this was very helpful, and she'll reach out.
Great.
Thank you, Lindsay.
Any other thoughts?
It was awesome.
Yeah.
Answered a lot.
It helped a lot.
Yeah. It was
Good.
very clear
Yeah.
and a good guide to get an idea of what the whole hospital and whole system is doing now.
It really breaks it down.
Also eliminates some of the fear factor, because when you see that they're taking 22 positions at the very top
Yeah.
and they're going to cut it to 10, that sure makes you nervous when you're at the very bottom, But now there's a different way of looking at it. There's a whole different, why do we do that? How are we getting max out of all those people? We didn't just all give them an 80-hour-a-week job now,
I will assure you that there's lots of thought going into, again, that the word value, right? So what is valuable? So if there's positions that have existed within our organization for many years, but they're not adding value anymore, it has nothing to do with the individual. But if you go back to that cost equation, we're paying people a lot of money to do jobs. If it's not translating to all those things that we just talked about, then we have to be thoughtful about, do we need that position anymore? Or do we want to take that money that we're spending on that position and translate it into 20 people in the front line doing something else, or something that's going to enhance our patient experience? And so we only have so many dollars and cents to go around, and how you use that becomes really important, especially if you're thinking about how do we do so at a lower cost to our community. And so you're absolutely right, and it does open up fear, I think, in everybody's mind. But what you have to know is that's being done with some thought and some focus to say, how do we restructure ourselves so we're sustainable, not just today, but way into the future? And we're doing so with our community and our patients in mind. And to me, that's what's really valuable about the conversation. That's what energizes me, is we're not just doing it for Christiana Care. We're really trying to do it for our state, for our community, for our patient population. So I think we're out of time. Again, I'd be happy to have conversations with anybody that's interested, or if you have questions, shoot me an email, pick up the phone, give me a call. If you want me to come back and have more conversations, let Cindy know, and I'm happy to do so. Okay.
Melanie said thank you.
Thank you.
Thank you so much, everybody. Thank you, Fran.
You're welcome.